Hi, everyone. Welcome to Bari Chat with Dr. Sayat, where we have honest conversations about weight loss surgery, healing, and hope. I'm Dr. Alvin Sayat, a bariatric and foregut surgeon, and also a bariatric patient myself. This podcast is about understanding the science, the stories, and the people behind metabolic surgery. So settle in. Let's chat.
Hi, everyone. Welcome to another episode of Bari Chat with Dr. Sayat. I'm joined here with Andrew, our nurse practitioner in the office here. We're going to talk about medical weight loss and how that can be an option for you in your bariatric journey. Andrew, I'll go ahead and let you introduce yourself to the folks and tell us about what you do here.
Thank you. Well, my name is Andrew Yelere. I am the nurse practitioner here at the bariatric and metabolic specialist. I have been in the bariatric space for about 15 years. I actually work in a hospital on the bariatric unit, became a nurse practitioner, and I've been spending more time here over the last decade helping patients navigate their journeys. I'm pretty much clinic-based, getting patient ready for the surgery, the patient for the consultation, then for the post-surgery follow-up, see them for the 1 week, 1 month, 3 months, 6 months, 1 year. Then I also do a whole section for medications for weight loss. I do them as a standalone for people without bariatric surgery. I also do them as an inpatient with a history of bariatric surgery. And I also do them inpatient in preparation for bariatric surgery.
Okay, great. Can you tell us a little bit about what led you to your path to the bariatric surgery and working in this clinic?
Yeah. So I started my journey as a nursing assistant at a hospital, and I did that for about 3 years. Then I worked as a bedside nurse for about 6 years. And my whole goal is to find a way to help improve quality of life. And I realized in healthcare or working as a nurse, I can do that in different facets or different forms. And after 6 years of working as a bedside nurse, I decided I want to do something different. And the opportunity to work with the bariatric population presented itself. So I started the bariatric program for Mineral Hospital. So I was the first bariatric coordinator. Started the program for them, get the first accreditation for them. And I just kind of fell in love with this part of medicine because when it comes to weight loss, you're dealing with people that are trusting themselves to you. So it becomes like a small family.
Mm-hmm.
And I ran the program for about 3 years and enjoyed all my time there. Then I went back to grad school. I'm a nurse practitioner, and I decided to stay in this journey.
Mm-hmm.
And so I started working with Dr. Fearing back in 2006. I haven't left since then. So this is my passion. I enjoy walking the journey with the patient. I'm going to start from prepping them for surgery, going into surgery, and see how this transpires from we can do these things to, my God, look at all the things I can do.
And so at what point in the bariatric journey, because this is going to be part of our series of the bariatric journey, would the patients necessarily see you versus like seeing Dr. Fearing? Like, how does that go for them?
So for the consultation for surgery, most of the time they will see the surgeon. After they've established care with the surgeon, and most of the time I am the next step. So kind of helping them with navigating what's required by insurance and helping them with making this lifestyle modification in preparation for surgery. So most of them will see the surgeon like the previous month, then the second month will be the nurse practitioner. Then we get them ready for surgery. Then the aftercare kind of kicks in. For some folks that are not interested in surgery, if they're just interested in medication for weight loss, then I'll do the consultation for those folks and get them ready.
So tell us more about because, that's the hot topic right nowadays is the GLP-1s and all the medications that come onto the scene. So what are the conversations you're having in that initial consultation with them? Like, what are those patients like asking for? What are their concerns? What are they looking for and educating them?
Yeah. So when they are here for discussion, I'll use the word discussion. So let's say they want to explore medication options. There are a couple components that goes with it. So there is the dietary component that we have to establish, and there's the exercise component and the behavioral modification component. So those things needs to be in place before we can incorporate any medication option into it. And I do know that there's a hot topic on the GLP, but there are other medications that we can use. And not every patient is a candidate for the GLP-1, either the oral version or the injectable. And they have to have the proper education that goes into it, because you also have to eat properly to get the best result out of it.
So who are those patients? Like someone comes to you and they say, hey, I want to be on Ozempic. I want to be on Zepbound. Like what's your decision tree of which medication is best for? And besides the GLP-1s, what are the other medications the patients are taking?
So we have to establish insurance criteria, because just like surgery, we have criteria that we have to meet for medication as well. And if you have a BMI that's over 30 by itself, you qualify. Or if you have a BMI over 27 with a comorbid conditions that goes with it. So high blood pressure, diabetes, sleep apnea, high cholesterol. Even though we have these guidelines in place, sometimes there might be some flexibility if your BMI is slightly below the requirement, because we try to treat each patient as an individual person. So the classes of medications that we use, and we try to use FDA approved medications for weight loss. The most common medication is phentermine, which is stimulant, help with appetite reduction, help with increasing energy expenditure. Some people like that because it's like a pick-me-up, give you some energy, but it does reduce appetite. Not every patient is a candidate for phentermine. So if you have controlled high blood pressure, you are on multiple antidepressants, multiple antihypertensive, history of heart attack, stroke, a major cardiovascular event, that's not a better drug of choice. So even though the patient say, hey, Andrew, I really want phentermine, everybody's using phentermine, I have to look at their medical history to make sure that they are appropriate. The second medication is Contrave, that's designed for people with cravings. It is a combination of Wellbutrin plus naltrexone. So if they are already on multiple antidepressants, may not be a better agent for them. If they have uncontrolled high blood pressure, may not be a better drug for them. Then the GLP-1, which is what most people are really looking into, they work very well. They cover a little more bases than the pill, but they also have contraindication that we have to look into. So the first generation GLP-1 is Saxenda, which we really don't prescribe very often. A little older generation, it's everyday injection. So it does have its pros and cons. Most people don't like to inject every day, but the side effect can be slow gut, nausea, vomiting, diarrhea. Then you go to your second generation, you're talking Wegovy, which is single agent, once a week injection. Most people like that, works pretty well. Side effect will be still very similar to Saxenda because they are all in the same family. So slow gut, nausea, vomiting, diarrhea, constipation, gastroparesis that people don't talk about. Then you have your newest second generation, that's a dual agonist. So Mounjaro or Zepbound. Zepbound will be the weight loss equivalent, or works on the GLP-1 and the GIP without any extra side effect. Weight loss is amazing. But again, if you have a family history of family history of thyroid, we don't want to use those things.
And then for those patients that are candidates for the medications, on the surgical side of things, we always talk about excess weight loss. What kind of excess weight loss is to be expected with the classes, and what are you seeing in the clinic?
Yeah, so with phentermine is a very older generation medication, and I think most people can anticipate probably a 5 to 10% of their excess body weight. If we can get 5%, I think we're doing well. The newer generation, so the GLP-1s, can offer anywhere from 15% to 20% of your excess body weight.
Yeah. And just so for everyone to know, when we're talking about excess weight loss, what we're talking about is that if you're 100 pounds over your ideal weight, and let's say either the medication will give you 15% excess weight loss, 20% excess weight loss, that's 15 to 20 pounds just losing with the medication alone. That's what we're talking about with excess weight loss. So in terms of the medications, in our world and on the surgery side, I've gone to the conferences and there was a big uproar about like medications versus surgery. But I went to another conference and I really like this frame set that they had, is that the the medications can kind of be viewed like on the parallel is oncology, where it's like neoadjuvant chemo and then adjuvant chemo, seeing which patients will respond to the medications and also using them as like an adjunct after surgery. Is that seem to be what you're seeing on your side of things? And is that really a better mindset to have in terms of the medications and surgery?
Well, we know that surgery is still the most successful tool that we have, given the longevity. The medications have always been present. They change every year, every 2 years. In patients that they're not a surgical candidate, I think it's a great tool to help get them to their goal. A patient with bariatric surgery, it is an amazing adjunct option because when they get to the point that they are at a weight stall or a weight plateau, dietary changes and an increase in physical activity is a separate portion that we can bring in that can help with appetite reduction, cravings management.
Mm-hmm.
So I like to kind of stagger them together.
Mm-hmm.
We have to make sure we find the right time to bridge them together. So we're talking post-surgery patient. We don't want to incorporate pharmacotherapy too early because it might just be counterproductive. We need to make sure that we've exhausted the first option first. Then we can stagger the medication on top of it.
And then how is the weight loss that we're typically seeing for patients after surgery when you add the medication? Does it have like an adjunctive, like an additive effect, like a synergistic effect where you're seeing more excess weight loss, or is it still about that 10, 15% or 15, 20%?
So I think it depends on how much they've lost primarily with the bariatric surgery. So if they've lost 100 pounds with the bariatric surgery, we don't anticipate that the surgery will give us another 100. But I think most patients will still get that, 10, 15, 20% of their body weight off in addition to bariatric surgery. It feels like a synergistic effect. It's like it compensates or it complements the bariatric surgery. And we also have to remember that when we're talking surgery and medicine, most of my surgical patients, they already have a nice established eating habit and exercise pattern. So putting the medication into it just make the result a little more robust.
Yeah. So it's nothing like any one of these things. And I'd say it on the surgery side too. It's not one thing is a magic bullet, whether it's surgery or medicine, but all of these things are working together. Kind of like how obesity is not just a one reason problem. It's multi. Yeah, exactly. On the other side of things, you touched on that, but I don't think it's talked about enough. What are the side effects that you're seeing most commonly in the clinic, and what is something that patients need to seriously consider or watch out for
with the medication?
So
I'll start with the pills. I'm just gonna go one by one. With phentermine, being a stimulant, so the most common side effect will be, or the most common complaint or discussion is insomnia. Being a stimulant, you have to take it early in the morning, so hopefully you can go to bed at night. But it can cause some constipation, can cause some dry mouth, and in some patients, they can have some slight increase or elevation in blood pressure. But in most of my bariatric population, I think constipation is number one because of the dry mouth. And with bariatric surgery, they just don't get enough liquids in. With the GLP-1, nausea is number one. And I think it kind of go in a circle because when you're nauseous, you're not getting enough liquids in, then you get constipated, then you kind of take more nausea medicine. So going to this circle. So nausea is number one with the GLP-1. Constipation will be number two.
And then, everyone always talks about the pancreatitis. Have you seen a lot of pancreatitis or anybody with that?
I think I can count on one hand how many patients have had pancreatitis on GLP-1. So hopefully the number stays that way, but that's always there. We always have to look for that. And that's why we have to have frequent follow-ups with patients. Your pharmacotherapy, this patient needs to be seen at a regular interval just to see how they're doing. And they also need to have access to you. So if they're having a lot of nausea, a lot of abdominal pain, a lot of bloating, then they need to reach out to the clinic and we can evaluate them. And the other part is the slow gut, the gastroparesis, which it's there and it is a discussion. But again, that's where we have to talk to patient. How's the GI habit? Are you having a regular bowel movement? Are you get your fluids in? Are you get your fiber in? And when they have any of this, you just have to stop therapy and have them come to the clinic and evaluate them.
Yeah, I mean, I need to look up the latest literature, but, just anecdotally, Dr. Scott and I were talking about how some of these patients can have the gastroparesis for a while, even after stopping the medication. So it is something definitely to think about for sure. But I definitely, I like the oncology parallel, and I definitely see it as like what you said, it's a synergistic, it's another tool in the toolbox, especially in the battle against obesity. I know you recently went to Obesity Week. Any new things coming out on the horizon? Anything to be excited about?
Yes.
Expected?
Yes. So exciting things in the pipeline. So working closely on the oral Wegovy. So that'll be the oral semaglutide that will be designed for weight loss. So we already have oral semaglutide, which is Rybelsus, assigned to people with type 2 diabetes, but we're coming out with oral Wegovy, and hopefully within the next 1 or 2 months, that should be available. And Lilly, there will be the oral version of Zepbound. So we're going to have the oral version for Wegovy. We're going to have the oral version for Zepbound. And so 2026 will be amazing for more options.
Absolutely. And they did that because patients then, even with 1 week, to avoid the injections.
Yeah, some people are just have phobia for needles. They don't want to do that. And we're also talking about cost. So when we talk about how much are this medication costing, if you talk about Wegovy and Zepbound, we're talking hundreds of dollars every month. The anticipation is that the oral version will be cheaper and more easily affordable for patients.
Yeah, speaking of the cost, that seems to be one of the main two things that we'll get in the clinic is that one, people don't like the side effects, but then the other is the cost. Like, what can someone expect on average to be paying for these medications?
So Wegovy, they just make some changes to the pricing 2 weeks ago. So this starting, and we're just talking people without insurance coverage. So without insurance coverage, you can get your starting dose of Wegovy for $199, and the max price is $349, which is significantly lower than what they used to cost. Even at $199 to $349, that's still a lot of money for medication. But that's the lowest we have right now. For Zepbound, starting price is $299, and the max is $449.
And this is per month.
That's per month. So we are anticipating that the oral version less than 50% of what the injectable cost.
Okay. Great. Where do you think the future is going?
The future's bright. I always think back to when I started practicing. Talk about the first generation GLP-1s, liraglutide or Saxenda. That was like everyday injection. A couple years later, we graduated to Wegovy, and a couple years later, we graduated to like a dual agonist Zepbound, and we're looking at possible maybe in the future there'll be a once a month injection, trying to fine tune what we already have with this GLP-1s to help with muscle preservation. So we're not going to muscle wasting. So I'm very excited. I think it just gets better every year. And it's like we're building on what I think there's also more emphasis and more discussion as towards the treatment of obesity as a chronic disease. So it's not just something we're going to solve today and it goes away. We're talking more about it. I think the conversation is more out there compared to, I'll say personally, when I started, I think, we just talk about diet and exercise, and now we are talking science because there's a scientific backup to the treatment of obesity.
Absolutely. No, I agree. I mean, just today there was a patient who was, felt ashamed or hesitant about talking about bariatric surgery because she thought that we were going to say that, you didn't diet and exercise enough, but don't worry, we're here to save you with surgery. And the first conversation that we always have is, no, it's not just just because you weren't disciplined enough or willpower enough. It is a chronic disease. It's multifaceted, multifactorial, a lot of hormonal effects. And we have evidence and science to back that up with surgery and with the medications. So, well, thank you so much. It was really enlightening. I always like to end the talk with, what's one thing that you want to leave the folks with, something that you want them to know about bariatrics bariatrics as a field, bariatric surgery, and specifically the medical side of things?
Well, I'll just say to wrap it up. You're not alone. This is we're all in together. Again, I've been in this space for a decade and a half, and I don't think I'm going anywhere. This is my passion. We are learning more and more every day on how to tackle this complex disease. And I think with more technology, we are advancing. So, I don't know what 10 years from now will look like. Even talking about bariatric surgery, we have newer procedures that we're doing now compared to 10 or 20 years ago. We have more tools, we have more technology. And I think hopefully in the next 10 or 20 or 30 years, that we have more tools and more resources to conquer or manage this chronic disease. The door is always open. One thing with my patient, I tell them is I'm available anytime. And I want them to have that connection and be able to reach me. Long-term follow-up is very, very crucial. It doesn't matter if it's surgery or if it's medicine. And study did show that patients that follow up routinely, they lose more weight and they lose more weight in the long run. So if you're starting medication, make sure you keep your follow-ups. We talk about the side effect. We want to know about them. Not one size fits everybody. As much as everybody wants the GLP-1, there are a lot of people that are doing well on phentermine, Contrave, and Qsymia. But just because you want to take phentermine doesn't mean I need phentermine. And also, we try to talk to the patient and meet them where they are. And start making those changes. So that's one thing that I took off from the obesity week, is trying to meet the patient where they are right now. Then we start making those changes. We don't need to make all the changes all at once. We don't need to clean up everything today, but starting where they are right now and making those gradual process.
No, I couldn't agree more. Well, thank you so much again for joining us. And thanks for having us here. Have a great day, everyone. Bye-bye.
Thank you for listening to Bari Chat with Dr. Sehat, where we have real conversations about surgery, healing, and hope. If you found this episode helpful, please take a moment to like, share, and leave a review wherever you listen. It really helps others find the show and join the conversation. If you have questions or topics you'd like me to cover, you can email me directly at drajsehat@gmail.com. And if you'd like to stay connected, follow the links in my link tree, right in the podcast title, for my social media pages, updates, and educational content. I'm Dr. AJ Sehat, and this is Bari Chat, real talk about surgery, healing, and hope. The information in this podcast is for educational purposes only and should not be taken as medical advice. Everyone's health situation is unique, and decisions about bariatric or metabolic surgery should always be made in consultation with your own physician or healthcare team.